evening. My name is Sandra Fritz, and I'm the chairperson of the Shrewsbury School Committee. Welcome to our meeting of October 28th. Tonight's meeting is broadcast live on Telco channels 29 and 329 and on Shrewsbury Media Connections website. I'd like to thank SMC Executive Director Mark Sarah, as well as Shrewsbury Public Schools IT Director Brian LaRue, who assist with our meetings each week. I'd also like to point out, as you can see, that we are meeting virtually. And the reason for that is because the room that we use at Town Hall, the Board of Selectmen meeting room, is also one of the polling places for our town. And it is currently being utilized as we get ready for the election next week. So that is the reason why we are meeting virtually today. First on the agenda is public participation. No one has asked to address the committee this evening, but if anybody wishes to do so in the future, please contact us at schoolcommittee@shrewsbury.k12.ma.us. Next is chairperson and members report. Does anyone have anything this evening? I'm seeing nothing. I'd just like to mention quickly, we did have a Beal Building Committee last night, and we do have those on a monthly basis. The building remains on plan. It's also under budget, so it's still a really good news story, hoping for that, open in August of 2021, but good news story, it's moving along. And we also had a meeting after that with the Beal Redistricting Committee. This is a committee that has been on hiatus for a little bit due to COVID. There was work going on behind the scenes with our consultants, and that will be a topic on our meeting agenda for November 4th for everybody to get an update on that. Dr. Sawyer, do you have anything under superintendent's report?
Yes, please. Mrs. Fritz, thank you. First, I want to start off by mentioning that the redistricting committee did meet last night, and restarting that work. Will be bringing some information to the school committee on November 4th about the restart of that important work as we look forward to opening the new Beal school next year. That construction is going well, as you just mentioned, and we're looking forward to that process. In addition to that, some good news. I want to mention that Walter Hildebrand, who's our athletic trainer at Shrewsbury High School, was notified yesterday that Walter was named the District E Athletic Trainer of the Year. That to me is excellent news, but not a surprise. He's an extraordinary athletic trainer and really makes a huge difference for our student athletes and the school community at Shrewsbury High School. So congratulations to Walter, and he now is in the running for the state honor as well, which from my perspective he deserves. We'll see how that goes, but congratulations to Walter on that honor. I also do want to mention something coming up this weekend in the community. There will be a virtual community walk and vigil for mental health that takes place this Saturday and Sunday, October 31st and November 1st. This is focused on walk again virtually at your own pace, using safe distancing in your neighborhood, wherever you'd like to walk. They're encouraging people to paint and leave a kindness rock in the Garden of Remembrance at Prospects Park, which is on 65 Prospect Street. There'll be some signs in the park that will guide you to that garden. It mentions here that painted rocks or compassion rocks are symbols of love, care, and support to anyone who finds them. And they're encouraging people to put those at Prospect Park as part of this. There will be a virtual vigil at 6 p.m. on Sunday, November 1st, where people can hold a candle at their home or on their walk to have a unified moment of solidarity. These were created to show support for those suffering from mental illness and to benefit the work of both Shrewsbury Youth and Family Services, as well as the work of Be a Bro, Walk for Zoe, who is walking in support of Zoe Wolfus, our high school junior who recently lost to suicide. It's focused on highlighting the need for increased communication and support around depression, suicide, and those struggling with mental health illnesses. And they asked that they, in lieu of a t-shirt, that there are donations made to SYFS or to the Walk for Zoe. So hopefully we'll have lots of people participating in that over the weekend. And then finally, what I wanted to mention is that the forecast for Friday is talking about some snow happening. And this is New England, of course, and this can happen in mid-fall. I'm expecting it's not going to have hamper our plans too much, but people have been asking, and the state did issue some guidance a couple of weeks ago that indicated that school districts are able to make the decision locally that if it's determined that students and staff who are attending school in person that it would not be appropriate to travel to school because of a weather event, that day, that there could be a remote learning day for all that day, and that would count towards one of the required school days and instructional hours towards our requirements. I expect that we will take that approach when we have snow days. We're working out some details. I will communicate something to the community tomorrow in the unlikely event that we would actually have to not have school in person on Friday. And then we'll certainly flesh that out more. But people have been asking that question, so I wanted to make that people aware of that as well. And that is Superintendent's report this evening.
Thank you, Dr. Sawyer. Our first time scheduled appointment this evening will be an update on the school reopening for the 2020-2021 school year, and I'll turn it back to Dr. Sawyer.
Thank you. Now I'm going to go ahead and share my screen and make sure people can see that slide. I'm going to put it on presentation mode. All right. Well, again, good evening, everyone, and looking forward to providing this brief update to you and then introducing a special guest that we have this evening to address the committee and answer some questions. I want to start again with our key messages, that of course, the health and well-being of our students, families, and staff is our first priority, that our focus this school year is to develop a safe school environment for our students and our staff that prioritizes everyone's well-being and enables high levels of learning for all. And that we're operating based on guidance from public health authorities, as well as the Mass Department of Elementary and Secondary Education, while very closely monitoring the latest information from medical experts and the evolving data regarding the pandemic, both here in Shrewsbury as well as across the Commonwealth. I want to express again how proud I am. Our staff continue to go above and beyond to make this all reopening phase of school. We just finished the 6-week mark. And I believe, by all accounts, we've had a lot of success. Obviously, it's not perfect, but there's lots of excellent work that's happened that's making a great difference for students. I really appreciate how supportive our families have been. We've had to reshape, of course, how our schools are working in order to adapt to this pandemic, and that is something that families have been very cooperative with and supportive of. And then our students themselves have been absolutely terrific in meeting all these new expectations, whether those are the expectations around the way they have to interact in school in person, the challenges of learning remotely. All of those pieces, our students overall have been doing a superb job. So certainly I remain very proud around the work that's happening around school reopening. I want to emphasize again that we need everyone's help in the community to stop the spread of COVID-19, wearing masks, distancing, washing and sanitizing hands frequently, using common sense outside of school. You're hearing a lot about this from the governor recently, particularly around socializing, obviously travel, and then of course also staying home if you don't feel well. And that's something, if you have anything that could be a symptom, being cautious about until those symptoms are resolved to make sure that you're not inadvertently exposing someone else. At this point, there's some new information that we're just made aware of in recent days. There was actually a webinar today that our Director of School Nursing, Noelle Freeman, who has been so key in leading all of our work around safety and health issues relative to COVID, was on that call. And at this point, I'm going to turn it over to her to give you a little bit of background about what the state is presenting as an opportunity for school districts to potentially take advantage of if it works and if it's a good fit and we're capable of doing that. So I'll turn it over at this point to Ms. Freeman.
Thanks, Dr. Sawyer. So as Dr. Sawyer just said, there was an informational webinar held just this afternoon about this phase 1 Abbott Binax Now Rapid Point of Care COVID testing for K-12 schools that's being kind of pushed out right now by the Department of Elementary and Secondary Education in collaboration with the Massachusetts Department of Public Health. So we just wanted to share some of the details that we know so far, knowing that we need to consider all of this information to determine if this is something that would benefit us at this point in time or not. Again, this is phase 1. They did refer to phase 2, but didn't really give any details as to when that might be or what any differences might be between phase 1 and phase 2. So the federal government is distributing these test kits. They're distributing about 150 million test kits across the country, and Massachusetts expects to receive about 2 million of them throughout as the school year progresses. And the intent is that they would be used in schools to do testing of symptomatic individuals. So this is not intended to be something that we could use for widespread screening of asymptomatic people. It only applies to people who do have symptoms. Binax now is a rapid antigen test. In general, these are thought to be less reliable than the PCR test, which is kind of the gold standard for COVID testing at this point. This particular test received emergency use authorization approval by the FDA in late August. And there was a small scale study, really only about 100 people involved in the study that was done by Abbott. That did show this particular rapid antigen test to have better specificity and sensitivity than some other rapids. That's something that Dr. Cianello can speak to much better than I can. But I will also say that the Department of Public Health shared today that they have another larger scale testing study done, currently underway at Lawrence General Hospital, and they're hoping that there will be results from that to share soon. And that will hopefully provide some more data on the reliability of this particular rapid antigen. So it's important to know that at this point, all rapid antigen tests, including this test, it's the recommendation is that whether you test negative or positive with a rapid antigen test, you should get follow-up testing with a PCR test to confirm or contradict the test, and the PCR result is what is the trusted result in what we would practice based on. So again, this would be for students and staff who are symptomatic in school. If we were to move forward with this, adding it to our protocols wouldn't really change much what we're doing, because we are requiring everyone who has symptoms to get a PCR test. So this would potentially give us some information up front, but again, it would need to be confirmed by a PCR. These tests would be free to districts. They did caution on the webinar that districts need to consider other costs, such as additional PPE that might need to be purchased. People administering the test need to be in full PPE, and of course the time and resources that it would take to implement this. Of course, there are other requirements for districts who choose to participate and are accepted into the program. A CLIA certificate, which refers to the Clinical Laboratory Improvement Amendments, which ensure quality laboratory testing, would need to be applied for and obtained. So obviously this kind of testing is not something we would typically do in school. So this is not a certificate that we carry or maintain. So we would need to apply for that certificate. We would also need a doctor's order, either from our own school physician or from the Board of Health physician. And staff would need training on how to administer and process the test. The test is a nasal swab that requires a reagent of some kind to be applied to the sample, and then it would produce a result in 15 minutes. So it's a quick test. You get the information rapidly, but again, would need to be confirmed by a PCR test. We would need to report results of the test to the Massachusetts Department of Public Health as any test site would. Again, something that we have not done in the past because we don't perform tests. The Department of Elementary and Secondary Education indicated on the call today that they haven't developed the system yet with the Department of Public Health for that reporting to happen, but that's something they're working on. And then in addition to that reporting, we would need to report any positive cases to DESE like we currently do when we have a positive case. So there is lots of information to consider. If this is something that we decide we're interested in, we need to complete a survey indicating interest by this Friday, the 30th. It is not a commitment, but they are asking districts who are interested to do that. So again, we are going to consider the information and make that determination by Friday.
Thank you very much, Noelle. And we'll hear a little bit more about testing from our guest speaker in a little bit as well. I want to just give a little bit of data about where we're at as a school district and a community before we invite our guest to speak. Again, this week we've had 2 cases in the schools in our hybrid model. That brings our cumulative case number to 21. We still remain at 0 with cases that are traced to exposures at school. And this week we've not had any cases in our remote program. We have a total of 3 cases since the start of school in the all remote program. We have begun publishing a data dashboard on Mondays. You can just a screenshot here of what you see if you go to that link that's listed there. We push this out by email every Monday afternoon. We have determined that we've been very transparent about letting the community know when we've had positive cases. What we want to be sure is we're not giving people overloading people with information either. So what we've determined is that if we do have a positive case in a school, the principal and Ms. Freeman and I will send an email to that school community as we have been doing. I will not be sending a follow-up email to the rest of the district. Rather, everyone will get the statistics for the entire district every Monday as part of the dashboard. The other part of the dashboard is shown here, which is just we'll show the past 4 weeks of cases. You can see we went from the end of September, the last week there. We had 3 followed by 4 cases. We had 6 the week of October 11th, back down to 4 the last complete calendar week, the week of October 18th. You've seen this slide several times at this point from Johns Hopkins from their website where they measure the positivity rates across all 50 states. You can see that Massachusetts still remains near the lowest positivity rate in the nation. It has crept up from 1.13% to 1.59%. Not surprising what we're seeing given the case climb we've seen in Massachusetts over the last several days. But again, far below the 5% threshold that the World Health Organization has set relative to a threshold for reopening or schools or the economy and so forth. This is our Shrewsbury positive test rate on a 14-day average, again, versus the 5% benchmark. And you can see that it's been somewhere above 1, but below 2, since they started giving us this statistic back in early August. It is at its highest rate since then at 1.79%. I think of interest is also that because Shrewsbury is not home to a college or university or a prison or kind of places where they're doing lots of weekly tests multiple times. They're typically people getting tested, or those for a variety of reasons, could be because they're symptomatic or concerned. Certainly people getting tested because maybe they're going to be visiting relatives or for whatever reason. But of the total tests that are given in Shrewsbury last week, it was a 1.79% positive test rate. Again, well below that 5% threshold. The state report, which is important, comes out each week. They're now coming out on Thursdays. Based on last Thursdays, Shrewsbury had 53 cases over the 2-week period they used, which is October 4th to October 17th. The 14-day average cases per 100,000 people was 9.6, which placed Shrewsbury in the red zone. It's important to note that the previous week, which was reported, I believe, on October 14th, for the time period September 27th through October 10th, there were 43 cases, which put us at 8.0 cases per 100,000. That actually had originally been reported as putting us in the red zone, but that was actually a mistake on the part of the state's reporting. It was misreported. 8.0 is actually at the highest level of the yellow zone. So we've been in the red zone technically for just 1 week at this point. Will there be a report tomorrow based on the cases we've been seeing, and the town has started reporting out cases on a day-to-day basis more frequently as of late. And based on the second week of the last 2 weeks, and then the last week that was completed as of this past Saturday, it looks like we're going to be right on the line again, similar to where we were on the October 14th report, probably somewhere close to 8. So we may be in the red zone still, barely, or we may be back in the upper range of yellow. We'll have to see tomorrow based on the case count that the state is using and depending on when they pulled that data out of the state system. But I wanted to make sure people understood that where we were relative to that color coding, which has had a lot of attention. I shared this slide last week, again, that there's been a recent report from the Rockefeller Foundation that talked about risk in terms of transmission in schools, and looking at that positivity rate and looking at the cases per 100,000 people, those two statistics I just shared. You can see that Shrewsbury is clearly in the lowest and lower transmission rates based on those two statistics. And before I turn it over to our guest speaker, I just wanted again to talk a little bit about the decision-making process in terms of what the state is advising us relative to the potential to move from an in-person hybrid model to all remote learning. And one of the key pieces that the experts are telling us now is really to look most carefully at whether there is transmission happening in schools. And you see there's a quote there that was put out by the Department of Public Health on October 21st. It was also communicated to us through the Education Department. And you can see the bolded part there that districts like ours who are currently open for in-person instruction, the state experts are encouraging districts to stay open, even if the local community is designated in the red zone, as long as there's no evidence of COVID-19 transmission in the schools. And as we've stated, we don't have any evidence of that in Shrewsbury at this point. So that's an important factor that we're looking at in terms of updating the guidance we've had from the state and updating our approach. Again, whether transmission is happening in the schools is the key factor. And since the beginning of the year, again, we've had 21 cases of people in our hybrid model. They've all, none of them have been traced to exposure in the school setting. And that brings me to introducing our guest this evening. We've made a commitment to consulting with medical experts all throughout the pandemic and determining how we can best move forward with our educational program in a safe way. And I'm very pleased to introduce to the committee Dr. Andrea Cirinello. She is an infectious disease physician at Mass General Hospital. She's an assistant professor of medicine at Harvard Medical School. She is a resident of Central Massachusetts. We were connected with Dr. Cirinello through our colleagues in the Northborough Southborough School District, which she is a part of that community. And she's been very generous with her time and her expertise consulting with us pro bono, and that's something that we really deeply appreciate. She has a tremendous amount of expertise. She is the communicating author and editor of the COVID-19 School and Community Resource, which is an online collection of research that's updated every couple of weeks or so around how the research around COVID is affecting schools and communities and helping schools and communities to make good decisions about their approach. So we're very pleased that Dr. Cirinello could be here with us this evening and looking forward to hearing from her. She'll have a presentation and then the opportunity for questions and answers after that. So at this point, I'm going to stop sharing my screen and allow Dr. Cirinello to share hers, and we'll turn it over to her. Welcome.
Thank you. Thank you so much for having me. It's nice to meet you all, and thank you for all of the work you're doing to keep the schools operating this year. I'm going to try to share my screen. Okay. Can you guys see my screen okay?
Yep.
Great. So I just have maybe 12 or 13 slides to run through, and I think we have till about 8 o'clock. Is that right?
Sure, we absolutely can take that much time.
Stop me if you have questions or want to ask anything. I think, Dr. Sawyer asked me to kind of give an update on what we've been learning about school reopenings this fall. And so, as he mentioned, I've been working with a team of physicians and researchers across the state to try to keep an eye on these data as they come out. So happy to give a bit of an update, but kind of want to start this from a place of humility and acknowledging that the data are not perfect, and they're certainly not everything we'd like them to be, but I think they are starting to show us some general trends that we can be pretty confident in. So I think the first, I'm going to start with my takeaways. I think, oops, if I can, I was trying to move the screen around here. I think, we started out at the beginning of the spring and summer trying to spend a lot of time as a medical community answering this question of whether children transmit COVID-19 infection, more than adults, less than adults, or the same as adults. And I think we spent a lot of time on that. It was actually a very difficult question to answer because the kinds of studies that we can do are really contact tracing studies and epidemiology studies. And it's just almost impossible in most of those cases to know who infected whom. So in a household, really hard to tell who was infected first. And so I think what we've started to learn is that that's really maybe like an interesting scientific question that we'll learn, after this pandemic is over. But I think for the purposes of making decisions about schools, really much less relevant than understanding what is the impact on schools of community transmission rates and of the mitigation strategies that we're putting in place in the schools, masking, distancing, ventilation, et cetera. And we are starting to see some data that have coming out from the US now about in-school transmission. And I'll go through some of those data, but overall it seems to be very rare. And somewhat surprisingly, even in places with moderate to high community rates of COVID. And when we have seen those in-school transmissions, it's usually been associated with lack of masking. And I'll give you some examples of those. And then a couple other things that we've been seeing emerge as really important issues are around testing and screening. So access to testing for staff and students who develop symptoms seems to be really variable. And I'm curious to hear how it is going for your staff and students in Shrewsbury. But it's definitely been sometimes going well and sometimes not going well across the country. And there may be a role for screening asymptomatic staff and students at some sort of regular interval that could help kind of be another level of protection. So I'll talk a little bit about what we know about that too. So just by way of background, I am an adult infectious disease doc. So I take care of adults. And so most of my patients that have exposure to schools are the teachers and the educators. And so I came into it kind of with that perspective, but we have been working with a large group of folks, as I mentioned, who are also pediatricians, child psychiatrists, adolescent medicine docs. And so I've kind of come to realize from all of these collaborations that there are several simultaneous things that we kind of have to hold true at the same time. So the first is sort of what do we know about kids and COVID? I think the data are pretty clear that children become severely ill with COVID much less often than adults do. As I mentioned, there's been a big debate about the degree to which they transmit. But I think an important thing to think about is that there is really an important balance of health outcomes. So infection with COVID-19 is one sort of physical outcome that we care a lot about, but there are a lot of other physical and mental health outcomes associated with, sometimes associated with not being in school that have been really important to learn about. And my colleagues share a lot of really good data about, for many kids, remote school or not being in school has been associated with things like increases in depression and anxiety and suicide risk, substance use, and some physical health manifestations too, like in some cases increased physical abuse or domestic violence, and interestingly associated with both obesity and malnutrition. So to put it in the context that COVID is an important health consideration, but certainly not the only one. And then educator health is a key priority, and I know sometimes has been absent from the conversations. And it's, I think, really helpful to realize that about somewhere between 25 and 50% of educators are either themselves at high risk for complications of COVID if they acquire the infection, or they have a high-risk household member. So keeping them safe is really absolutely critical as well. And to keep that in mind every time we hear that, kids don't get that sick with COVID, but they're not the only ones in the building. And then considerations of equity, which I'm sure that you guys have talked about a lot, but across the United States and here in Boston area as well, just to remember that Black and Latinx communities have been really disproportionately affected by COVID, and also sometimes really disproportionately affected by the impact of the various school models that are available. So data from across the country suggests that Black and Latinx communities have less often had an option to select in-person school. They've only had maybe remote options in their districts. But interestingly, when there is a choice offered, may be more likely to select to select the remote school instead of the in-person school as well. So I think, there have been stories of students who actually did very well with remote school and found that it addressed some of the concerns they had with in-person school, maybe potentially experiencing less racial microaggressions or fewer, race-based punishments and things like that. So those were important things to hear too, I think, in that potentially our role in improving the safety of school can really just be to give families a choice to make the decision that feels best for them now. And so as much as we can make schools safer, facilitate that choice being a bit more balanced in terms of COVID risk in the schools. And then another sort of key piece of background is, I think there's really two factors to think about in thinking about COVID-19 associated risk in schools. And the first is sort of what is the risk that someone with COVID will walk in the door? And that depends on what's going on in the community. What are the community rates nearby, as we just saw? And also, what are people doing out of school? What are the exposures that they're having? Are they getting together? That kind of thing. And we can't control most of that probably, but the other really important factor is if someone who is infectious with COVID walks through the door, what is the chance that they will transmit to someone else? And that's where all of these mitigation strategies come into play and are, I think, proving themselves to be very, very effective. So things like masking, distancing, ventilation, cleaning, all of the things that the school has been working really hard to do. I like this graph. This is from the Cleveland Clinic, but also adapted in the Children's Hospital of Pennsylvania guidance that we'll talk a little bit about. This is sort of the Swiss cheese model and kind of just illustrates that if you can set up all of these sort of redundant approaches to protection, you can probably minimize the chance that, a little virion makes it through all these holes in a row. So this is just to emphasize that all of these things are really helpful. And I think this is why we're doing all these things. So some of the data that we have, I think when we talked in the summer, we had very reassuring data from international settings about schools being able to open without in-school transmission. These were really in places with very low community rates. And then subsequently to that, we've seen some data from Europe, Spain, Germany, and the UK. Even as rates started to rise a little bit again, really no impact of their fall semester school reopenings on the rates in the community. So a lot of people have wondered, like, if we open schools again, will it be a driver of community transmission and will the epidemic surge? And they really haven't seen that. And they've had a large number of students in school with very few outbreaks. So focusing on that in-school transmission component. Some of the data that we have from Massachusetts, I'll share here. So DESE has been for the last 4 weeks, putting together a spreadsheet, which you can access on their website, that lists the number of school-associated cases. And so they don't break down whether there's been any evaluation of whether transmission occurred in school. They're just reporting sort of, cases associated with the school. So this could be that sort of who walks in the door kind of component. But the rates are, I think, fairly low. Out of 75,000 staff who were present, these are data from last week because that's the first week for which they gave a denominator. So there were 75,000 staff that were present in a school building in either hybrid or full-time learning, and only 73 infections, so a risk of 0.09%, and 450,000 students who had some presence in a school building, with 129 infections, so 0.03%. So these are very low. I don't know how complete these data are, to be totally honest, but from the data that we have, these are looking, like low risks and lower than in the communities. And then New York City, interestingly, did some random COVID testing on more than 16,000 asymptomatic staff and students and found only 28 positive for a risk of 0.17%. So that is also kind of a nice low risk. The other source of data that I think is really interesting is this data dashboard that's been put together by the Superintendents Association and Brown University. It's led by Emily Oster, who's been working on this all summer and trying to get people to contribute to this data set. So it is voluntary reporting. In medicine, we tend to think that voluntary data sets tend to overestimate bad outcomes because people notice them, they're worried about them, they report them. You could imagine that the direction of bias might go the other way too if schools are reluctant to report cases associated with their setting. I don't know which way it goes, but in any case, it's clearly a limitation. And then there's also no formal statistical comparison. So if you wanted to look at this and compare, remote to hybrid, I can't say for sure whether these numbers are actually different from each other at all. But I think they are, and the other key limitation is that these are, again, just like who walks in the door kind of cases. There's no attempt to tease out whether these were in-school transmissions. But they give you some sense of order of magnitude, kind of comparable to the DESI data. So overall, across the US, COVID-19 has been reported in 0.5% of school staff and 0.2% of students. And then it's a nice data dashboard, and I'll send the link, or it's in the notes of the slides, I think. But you can play around with these different predictors. So you could look at all schools, you could look at schools that are remote. You can also look by masking and distancing, although I think those data are really incomplete, so I didn't include them here. But for example, you can look at all schools across the US. These are the numbers I just told you for students and staff. If you look at remote only, it's not reported for students, interestingly. For staff, it's 0.35%. So if you look at schools that have hybrid or some sort of reduced capacity in-person education, the risk in students is 0.176%, and in staff, 0.48%. So, is this statistically different than 0.35% for remote only staff? I don't know. And then full-time in-person schools may be trending towards a higher risk at 0.3% in students and 1.1% in staff. And interestingly, if you toggle around with the full-time in-person and you take away, you only look at schools with no masking, for staff, it's like 6%. So there maybe is some trend there, but I think the data are not ready really to be analyzed in any formal way. And then I think, we're hearing this story that seems to be growing about there really hasn't been a lot of in-school transmission anywhere across the US. And I always think it's helpful to kind of say, well, what data do we have that shows the opposite? And we don't have much. These are very poor quality data, but I think it's important to try to drill down on where we do see transmissions that we think are happening in schools or childcare centers. What were the conditions in which that happened? So there is a CDC report on daycare centers from Utah that found 3 facilities out of a very large number that were open, but 3 facilities with in-facility transmission. The students were all unmasked, largely because it's a daycare and they're very young. But the 3 facilities that had at least one sort of transmission in the center were associated with the staff being unmasked. And in the case of the largest outbreak, a staff member who was working while she had a household member at home who was symptomatic, who later turned out to have COVID. So potentially had an exposure that wasn't like quickly identified and worked during that time when she was infectious. And then we have some anecdotal data like reported in the lay press, which is, I think, I'm always reluctant to really put a lot of faith in that, but some examples, for example, from Lincoln, Nebraska that made the press, where they had, again, in a very large district, they had 4 evident sort of instances of in-school transmission associated with 9 people. 2 separate instances were 2 separate high school students, not linked to each other, but one transmission that was at lunch inside the school and one that they thought was at lunch outside the school, like on campus, but sitting outside. So I think that's interesting because we've been using that as sort of a way to minimize risk. I don't know how closely they were sitting together or what the situation was. And then 2 staff members who are actually in non-student facing roles, but have a shared office in which they didn't use masks. And then a group of 5 staff members who ate lunch together in a break room, again, without masks. So I think, that sort of particularly like staff to staff or older student to older student transmission when masks are off, especially around eating, is a risky period, but in general, pretty low risk. And then I think people probably are familiar with this Israeli outbreak that was reported over the summer. That was really, I think, a good example of kind of what not to do, where they had, they initially came back with a mask mandate and lower class sizes, and then they increased the class sizes, and then they had a heat wave for 3 days where they removed the mask mandate. So they had like 38 kids in a classroom. It was 100 degrees. Everyone took their masks off. And then there were, 50 some cases in the school that came from 2 symptomatic students. So I think we know not to do that, but it's like a helpful lesson in that. I think masking and distancing seem to really be working. And ventilation, they had some very poor ventilation in that school as well. So I think, one of the really useful sources of data all throughout the pandemic so far has been from CHOP, which has a policy lab focused on schools. And they put out some guidance earlier in the summer that actually used, they gave very clear and very conservative community thresholds for having in-person schooling. And then they revised that last week And they took away those thresholds, and they said, you know, we've actually found in our review that when schools have these mitigation approaches in place, they can actually effectively prevent in-school transmission, even in communities with what they called moderate incidence. So 30, which they defined as 35 cases per 100,000. So this is, you know, substantially more than we're seeing in our towns as of right now. So, you know, we're thinking about, are we popping up above 8 to be in the red, but this is much, much higher. And then this is the thing I've been trying to find data on, and I just don't think they exist yet. But, you know, there is going to be someplace a tipping point where no matter what we do in the schools, the community risk is just too high that we just can't overcome it. But it may actually be extremely high. Like, no matter how many people come in the door, you may be able to prevent them from passing it to each other. And we don't know what that tipping point is. And then, sort of similar to what we talked about before, most of the school-associated transmission has occurred either outside of school or because of poor adherence to masking. And some of the examples are here: student gatherings outside of school. I know we've seen that in Northborough, Southborough. Shared meals among staff, whether they're doing that in school or, you know, dinner on the weekends. And then youth sports has been, they actually chopped as a nice review of youth sports. Most of the transmissions that they found were associated with interactions that were not on the field of play. So more like sidelines, locker rooms, pasta parties, things like that. And then teachers, staff, and caregivers, as we know, are more likely to become ill because they're adults rather than kids, and potentially to transmit. Certainly what we've seen is because of the sort of break room kind of behavior that more transmissions have been associated with adults. And just as I know that your district has thought a lot about, but flexible sick leave for people so they don't have to come to work when they're symptomatic, an adequate space for breaks in eating where people can be unmasked at a distance from each other, ideally outside, or someplace with good ventilation, I think are really important. This is just to give a little more context around the 8 per 100,000. So, you know, I thought it was interesting to look what other states are doing. Arizona, they are saying their threshold for in-person learning is 100. You know, Washington a little less. Oklahoma has a range. The Harvard Global Health Institute gave this recommendation 10 to 25 per 100 earlier in the summer. Massachusetts, as we just talked about, was 8, but they just clarified that, as Dr. Sawyer just said. And then the previous CHOP guidance was very low at 5, but again, they just took that away. And then people also ask us to consider test positivity rates, but they don't actually tell us what to do with that information. It's just like one thing to consider. And I think it gives a sense of how much these case rates per 100,000 are missing people. Because if your test positivity rate is really high, you're just not testing a lot of the people you need to be testing. You know, we as a group are not doing that as a society. So that might give you some sense that your numbers are being underestimated. And then I was going to talk a little bit about testing, but maybe I'll stop there and see if people have questions or anything I should add.
Anybody have any questions? Just speak up.
I wondered, Dr. Hi, my name is Lindsay Heffernan, school board member. One of your earlier slides talked about the DESI data that was more recently released and for in-school rates. Do you know, or is it knowable if DESI is only collecting public school data, or if that's including private schools, which are, you know, functioning oftentimes fairly differently than how some of the public schools are functioning when it comes to in-person?
Yeah, that's a great question. I'm pretty sure that they're collecting all different categories of schools and that they're broken out. I just looked at those today, but I know they have like special education schools. Okay. And I can actually just look quickly and see what those categories are, because that is really
yes. I can. All schools in Massachusetts are required to report to DESI, not just public schools.
They are all there, but they're not broken out. It's district. It's education collaborative and special ed schools, and then the total in the district.
Okay.
So I think private schools are included, but not reported separately.
All right, thank you.
Ms. Fritz, if I might.
Sure, Jason.
Doctor, first of all, thank you for the presentation. Just a question. Obviously, you talked about, you know, the tipping point for community transmission and where that might, you know, be relevant to a school conversation. And obviously, to your point, we don't know where that is yet. Do we have reason to believe that there is even a statistical relationship between community transmission and transmission in school, or schools becoming unsafe? So for example, obviously the practices of small children and staff in school are not per se the same as adults in the general population behave, even though we don't know at what point the community transmission rate is going to present an immediate problem for schools. Do we suspect, other than anecdotally, do we suspect that there's a proportional relationship there?
I think it's a great question. I don't know. I haven't seen anyone really provide even modeling estimates on that. So a lot of the information that we are thinking about comes from sort of computer simulation models of schools, where you can simulate the movement of students and the movement of teachers through the school and outside of the school. And I think there's sort of an interaction between the risk that someone walks in the door with COVID, which is the community rates, and then the efficacy of all of these mitigation strategies. So if you have a lower efficacy of these mitigation strategies, then as soon as you reach kind of a level that's probably in the like 5 to 10 to 15 per 100,000 range, you start to see propagation in the schools. But if those mitigation strategies are really effective, you can sort of drive the like in school R naught value down well below 1. Then those infections come in, they make a lot of headache for quarantining. So at some point, it's maybe operationally becomes a little bit less about in-school transmissions and more just about the fact that like so many people are quarantined that you can't actually, staff the school. And that's not because they're transmitting in the school, it's just because so many people are coming in and they are exposed to people who you have to quarantine even though they never acquire infection. Does that make sense?
It does. Thank you.
Anyone
Maybe
else?
before we go on, maybe at this point, I would ask Ms. Freeman to comment a little bit. I know the slide earlier talked about, cases coming from outside, and maybe Noelle, if you could give a little bit of insight in terms of what we're seeing in terms of as we've done contact tracing for cases that have become apparent in our schools.
Sure. So when we're looking at the possibility of in-school spread and making that statement that we have not seen in-school transmission, we are looking at all the cases in a given building and comparing the schedules and shared spaces and activities as part of contact tracing, which I talked a little bit about a couple weeks ago, to determine if there's any commonalities or crossover between any two or more cases. To date, we haven't found that this is the case in school. We have had several cases, more than half of our cases in the schools have had clear links to positive cases outside of school. So, for example, when an individual in a household has tested positive and then the rest of the family members are told to quarantine and be tested, and then subsequently find out that they are positive. We've had several situations where that is the case. So there's a clear link to the household. And on a recent DP8 Massachusetts Department of Public Health webinar, they talked about the prevalence of household or single address clusters across the state. So that's certainly not unique to Shrewsbury. And it makes sense with the kind of contact that you're having with people inside your households, unmasked and closer contact. We have also had a couple of individuals who were involved in sports teams, such as a hockey team or a basketball team outside of school. And while we were not informed of a direct link to those cases, I think a lot of people are aware of the hockey shutdown that has been put in place across the state, because they have seen, public health has seen that activities like that are contributing to clusters and spread. So I think it's just a reminder for all of us that what we do outside of school definitely impacts the positive cases and what we're seeing in school.
This is Dale McGee. Can I ask a question?
Or Dr. McGee?
Okay. So Noelle especially, I'm interested in the information flow as to how you learn about cases. For example, if someone is in the community, they go to the doctor, they're diagnosed with COVID, I imagine that often that is reported to the Department of Public Health. If they have a test done, I imagine the lab has to report that to the Department of Public Health. You are seeing people who report to school staff or to you, have symptoms, have a test, and they tell you that their test was positive. With regard to remote students, I would imagine that many of them may not feel the necessity to tell you that they have a positive test. They kind of are already quarantined to their mind. So could our estimate of remote students who are positive be an underestimate?
So that's a great question. We have had a couple of people in the full remote program report directly to school. And we've also had one case that I can think of where we got that information from the Department of Public Health. But when Worcester, when Pat Bruckman sees a case that falls within the school age bracket, she will reach out to me and ask me to check to see if that person is a member of our school community. And if they are, then I am able to then report that as a positive case in the remote community. So I feel like we are getting that information one way or the other.
Okay, well, that's great. Excellent. And a question for Dr. Serenello. Your slide, I think Lindsay touched on this, the slide that has the Massachusetts reporting program regarding positive cases. That is a voluntary program among the schools. Lindsay, I think, was asking about whether it included private schools or not. The reporting there, it's from the schools to DESE. It's not from the Department of Public Health to DESE. And it's a voluntary program. If I'm not mistaken, I believe this was reported in the Globe a few weeks ago, and the number of positive cases that had been reported to DESE was a fraction of the number of positive cases of individuals in the 5 to 20-year-old age group.
Yeah, I really wonder about those data too. We had a really good call with DPH the other day where we were trying to encourage them. I think you have maybe had a similar conversation in Shrewsbury, but trying to encourage them to provide more information about the contact tracing and to add a lot of data to their contact tracing questionnaire around schools. And I think they had already moved in that direction, so that I don't know if it's come out yet, Noelle, but there's the next iteration of their form that the local boards of health will fill out will have more information about schools, including things like, do people think there was an in-school transmission? Not a lot of detail beyond that, but at least the question. And then, were they involved in a remote or a hybrid learning model, and or in person, and some questions around sports, but not really distinguishing between school sports and club sports and things like that. So at least that's an improvement. And they seemed interested in looking at those data. And I have a colleague who's working closely with DESE. So we were trying to sort of link DESE DPH to see if we could get their data to at least be sort of harmonized in a way that we might be able to compare them. But I think just anecdotally, I think we've had cases in Northborough, Southborough that then didn't seem to pop up in the DESE spreadsheet. So I
can maybe speak to that just briefly. So what we have been told, and Dr. Sawyer can chime in as well, what we've been told by DESE is that they are not reporting remote cases. So they want us to tell them about them, but they aren't including that in their number. And one of the questions that I get asked by DESE when I call to report a case is, was this the individual, the student or the staff person in school within the last 7 days? And if the answer to that question is no, then they don't include that person. So they could be in the hybrid program, but they haven't been in school for more than a week. So they don't count that case for some reason. So there's a lot of difference in the numbers.
Yeah. Another variable that's in play is the 3 foot, 6 foot pronouncement. DESE has said 3 foot is safe. I'm not aware of much in the way of data regarding that from a point of view of research, and I'm not aware of comparisons with real world data regarding how that's turning out. And I think that one of the criteria for having a significant exposure is you're within 6 feet of someone for more than 15 minutes. And so there's a conflict in the way information is being given. On the one hand, we're hearing that 3 feet is a safe alternative, and we certainly can't open our schools without 3 feet being a safe alternative. On the other hand, they're saying, if you spend more than 15 minutes during the day within 6 feet of someone who tests positive, then that is considered a close contact. So those two things don't sit well in the same paragraph.
Yeah, I think you're absolutely right. There are not good data on 3 feet versus 6 feet. And I was really hopeful that that database from Brown and the Superintendent's Association would provide some data on that. Currently, I think the data reporting is still too limited because you can toggle 6 feet on or off, and it just, the data don't seem to make any sense. So it's like there's like big gaps and charts disappear, and yet I think they're working on that.
Mhm.
The data that we had scientifically were really around data primarily initially derived from other respiratory pathogens, and then a little bit from SARS-CoV-2, but all without masking. So it's really hard to know sort of 3 feet versus 6 feet in this context of universal masking, whether that will make any difference at all. So I think we hope to get data actually as schools do this, but we don't have those data yet. But I always just come back to the idea that there's sort of what makes you a close contact formally. That means you need to get quarantined and tested. And then there's like, what is the actual risk for acquiring COVID? And so we are quarantining those people and being very careful and following those cumulative 15-minute 6 feet guidelines. But if everybody is masked, we're really, not seeing transmission even close up. And I am always comforted by the hospital example where,
Right.
as in the hospital, we're all masked, but we're all sitting on top of each other all day long and nobody's 6 feet apart. And that so far we're not seeing, transmission from staff to staff as long as people are masked.
If I could also just add a couple things to Dr. McGee's question. First off, I think since that Globe article was published, the Commissioner of Education made it clear that it was mandatory to report cases to the Department of Elementary and Secondary Education under the governor's emergency orders. So that is a mandate. And looking at the spreadsheet, just to be clear, there are some private schools, but they're approved special education private schools. So essentially the only mandated reporting in the data set that they have has to do with educational collaboratives, approved special education schools, and public school districts, which would include charter schools. But other private schools, such as parochial schools, boarding schools, they are not reporting to DESE. So that's, however, I did confirm with our local public health authorities that they are required to report to local public health. So in terms of whether there'll be an opportunity to gain, and I know that's something that I'll be communicating with local school leaders in the near future, is whether or not we can do something sort of in a collaborative manner here locally in central Massachusetts to see if we can get some data relative to schools that might be doing things differently in terms of distancing or and seeing what kind of results there are. But the mandated reporting is really only for those associated that are overseen by DESE itself.
Anything else before we move on?
It's, I have to comment on an article that Ms. Heffernan said to me this afternoon. It was an exploration of the Catholic schools in the Diocese of Boston. And with 35,000 students, 2/3 of which were full in person, their rate of COVID positivity since the beginning of the school year was about 1 in 700. I don't know where this author got it, but that's public health gold there.
Yeah, that's great. Thanks. And I don't think that the DESE data are sort of, I think they're just lagging a little bit. Like when we were saying, we didn't see some cases pop up in the week. I think it probably appears in the next week. It's just, there's a bit of a delay. So hopefully we'll continue to sort of expand these data collection efforts, because I do think they're really critical, and adding the parameters that we've talked about to help us understand what approaches are absolutely critical and what maybe 3 feet versus 6 feet might be modifiable, I think will be really helpful. Dr. Sawyer, should I do a couple more slides on testing, or do we want to move on?
Well, I think since the state's offering this opportunity, I think it'd be great to see a couple of slides on that, and then maybe a couple more questions would be helpful. Thank you.
Sure. So I have a lot more information on specific tests. Like if people want to talk about the Binax now in detail, I have other slides on that which we can talk about. But this was just one quick slide on symptomatic testing. I think across the state, we've seen really variable results, but it's all been very anecdotal in terms of how quickly people are able to get a test on the day that they develop symptoms. and how quickly they're able to get the results back. And I think this is really critical because on one hand, I think it helps people report their symptoms honestly if they know that they can get tested easily and get back to school quickly when it's most likely not COVID. Whereas if you knew you had to like wait a few days to see your doctor and then wait a few days to get the result, you might just sort of try to ignore your sniffle and go to work or school. So I think it's important in that regard. And then I think certainly facilitates timely return to school and return to work. So reduces the need for substitute teachers, reduces the days lost from in-person education for students if the test is negative, and then allows, probably even more importantly, like really prompt isolation and contact tracing if the test is positive. And then most of the districts are suggesting the use of a laboratory-based PCR in place of rapid tests for the reason that Ms. Freeman mentioned, just sort of really a lot of false positives in addition to false negatives in a low prevalence situation. And then there's been a lot of interest of late in screening. So testing is focused on evaluation of people with symptoms or contacts of people with COVID. Screening is sort of regular testing at some interval of people who are asymptomatic. And we talked about the Swiss cheese model, and hopefully screening could be sort of just another level, even before the virus walks in the door, to help quickly identify people who might be infectious and isolate them out of the school setting before they can pass infection to others. It's certainly being widely implemented. It's been, I think, well known in the press. Many colleges and universities are doing this. Many K-12 private schools in Massachusetts are doing it as well. And then coming back to some of those computer models that I talked about earlier, when they've simulated weekly screening, it seems like it might allow K-12 schools to have full-time 5-day in-person school at a similar total risk of infection that a hybrid model might experience without screening. So it might be a way to kind of get people back into more full-time in-person school. And that's especially true when there are high community transmission rates, which makes sense. So more people kind of coming in the door, you can find them and kind of take them out of the school setting before they pass it on. And so there are a number of K-12 public schools that are piloting weekly screening. There's a collaborative called the Massachusetts Safer Teacher, Safer Student Collaborative, which is a really nice group of districts that is now, I think, 12 or more districts, including Revere, Cambridge, Somerville, were part of the original founding groups, Wellesley and Watertown. Of those, so far, only Wellesley and Watertown, I think, are really moving forward with weekly screening of students and staff. Some of the other districts are working on it, and some of them are not open for in-person school yet, so have hope to do this once they are able to open. Cambridge and I think Arlington are screening their staff weekly. And then I mentioned the New York City public school screening data, and then there are many others across the US as well. So I think this is potentially an exciting area of it and sort of an additional level of protection that we might be able to offer. There are a lot of logistics to be, there's my second grader. There are a lot of logistics to be worked out. And also the cost right now is still quite high, but a lot of efforts are ongoing to drive the costs down. And here she comes just at the perfect time because I was going to stop and say thank you and see if anyone had questions.
So bye.
I'll come up in a little bit.
Anybody have any questions, comments? Just
Can you advise us regarding the decision that we're being offered regarding testing in schools?
In terms of the Binax now?
Yeah.
It's an interesting question. I think there are a couple of issues. I think one is is the test good enough? And two, how easy is it to actually operationalize in the school setting? So is the test good enough? It has a sensitivity that is much, much higher than the previous rapid antigen tests. So I think we spent a lot of time telling people not to get antigen tests, but the sensitivity is sort of the ability to detect disease when disease is there. So if it's low, you have a lot of false negatives. And you don't want to have false negatives if particularly that is a problem if your suspicion is very high. You just don't want to miss these conditions. You don't want to miss a true COVID infection. So the PCR itself is not totally perfect. And all the data that we have about the antigen test is comparing it to PCR. So from the data that were submitted to the FDA for the emergency use authorization, as Noelle mentioned, it's just about 100 people, but the sensitivity compared to the PCR was about 97.5%. This is much, much better than the other antigen tests, which are about 70%. And so the PCR sensitivity itself is probably around 90 to 95% if you catch somebody early in disease. It's a lot better than we thought it was early in the pandemic if you get people in the first 5 days. So this is, 75% of that. So it's actually pretty good. And if you consider that most people who have the symptoms that they're getting tested for probably don't have COVID, it's probably good enough. I think the question is, do you trust the data from 100 people, or do you want to see bigger studies before you implement that? A bigger concern potentially is that the specificity is pretty low. So the specificity is sort of the opposite of, it's a false positive rate, essentially the opposite of that. So how likely are you to find no disease when there is no disease? And if you have a low prevalence of disease, even if you have a really high specificity, the number of positive tests that are actually true positives can be very low. So the antigen tests that we're familiar with, the sort of, the BD ones and the ones that people have been getting in the community, those have a specificity of about 99.6%, which sounds really good. But if you have a community prevalence that's like 1%, about a third of your positive results will actually be false positives. The Binax now, the new one, is actually lower than that. It's about 98.5%. So that could be quite a big number of false positives if most of the people that you're testing don't have COVID. So I think that's part of the problem. And then another challenge is just how would it be implemented in schools? Like, would it take a full-time school nurse to be doing this? You have to sit and run the test on the machine, and it takes 15 minutes. And what kind of PPE would that person need in order to be doing their anterior nair swabs? So if the person's old enough to self-collect and you think they could get a good sample, they might be able to do it, and you could be far away without full PPE. But if you need to help the students do it, for example, then you need full PPE for the staff. So I think there's some operational questions. We're not sure at least I'm not sure if there's going to be a cost to schools to implement them. And so that may be part of the consideration as well.
So the tests themselves, the test kits would be supplied free. So they just cautioned that, like you're saying, there could be other costs to the district with the PPE and just the personnel that it might take to implement.
So I'm struggling a little bit with it. I think if you're having a lot of trouble getting people tested quickly and getting results back quickly, it might be something to try. If you have a good system in place where people are able to go, to any of the local places and get tested with the PCR and get results back in 24 to 48 hours, that might be preferable.
Do you have concerns regarding the accuracy of students self-swabbing nasal swabs?
It's a good question. The data on self-collected anterior nair swabs are good. I mean, they sort of compare favorably to the, provider conducted nasopharyngeal swabs, but I don't think those were done in people under 18, those studies. So there is a quality control aspect of the assay. So it will tell you whether you have sufficient number of cells, for example. I haven't seen this one assay, but I think when I read the documentation from the company, there's a QC included. So hopefully would know if you got a really bad quality swab, but I'm not sure.
Thank you.
I wonder, Noelle, if I can, Ms. Fritz, what you think what confusion we might cause to the parenting community that we're running testing, but then we're also saying you're going to need another test. I think there's lots of confusion. You've used a lot of words between these two doctors in the last couple of minutes that not everybody understands. And so I worry just about what challenges that might present, or frankly, what just frustrations that the school is doing testing, but it's not good testing. You're doing bad testing when you do it again. And that's what, and maybe where it has some additional cost and we're causing headache. I'm failing to see the upside. So I will defer to those on the call with medical expertise, but I feel like as a parent, I'm thinking, in the last 2 weeks, I've had to have 2 of my children COVID tested, and my spouse is actively getting COVID tested right now. So I'm like, we're doing lots of COVID testing just because of exposure. But and all of those have been different, some easy, some hard. But to learn that the school is doing testing and you need to go do it again anyway. I wonder what your thoughts are, Noelle, about how that conversation would feel for your school nurses who would bear the brunt of that conversation, I would have to imagine.
Yeah, I think it's an excellent point and something that Dr. Sawyer and I have talked about, that I'm not sure with the way that it's being rolled out right now, how much it would add to what we already have in place. There was some concern from people on the webinar today as well about, would some families feel more like they should send their child with symptoms to school? We've had great luck with people keeping kids home if they're sick, and that's so important. But would some families think, oh, well, they can go and they can get some kind of test at school if they have symptoms at school, and send them to school with symptoms, which is something that we would definitely want to discourage. So I agree that it could cause some confusion for families. And at this point, where it can't be used as kind of a screening tool, I don't see it adding a lot to what we're already doing.
So, Ms. Fritz, if I may, just I want to be sensitive to Dr. Cirinello's time and getting her back to her family. And maybe just a wrap-up question, if it's okay, and fairly straightforward. Some of your slides and the information you shared, Doctor, were about the varying recommendations around the cases per 100,000 and what those numbers are like. And I know that Massachusetts seems to come across as a fairly conservative number, with the 8 per 100,000 being the threshold to go into the so-called red zone. With this newest advice from the Mass Department of Public Health, that school districts like ours and Northborough, Southborough, that have students attending in person, the community might go into the red for some number of weeks back or forth. And I know they've been asking us to look at multiple weeks of data, because those can go up and down a bit depending on the larger community piece. But given the research that's being done and that you're seeing around in-school transmission, or the lack of it, with the proper precautions, in this advice, this newest advice saying they really advise school districts to keep their in-person programming, even if the community is in the so-called red zone, as long as they're not seeing transmission in schools. Is that something that you're seeing is getting widespread concurrence among you and other experts in the field here in Massachusetts?
I think so. I think everyone that I've spoken with has been pretty comfortable with that. I think as long as these mitigation approaches are in place, and we're not seeing, we're doing good contact tracing and we're looking and we're not finding evidence of transmission occurring within the schools, then I think that's sort of the most we can do. And, people could acquire their infection really anywhere. I think the question is just, is it higher risk for them to be at school than not to be at school? And it seems like if we're able to keep all these protections in place, that it's not.
Well, thank you. That's very helpful.
Well, thank you. I know we've kept you long enough tonight. I think
I'm happy to stay, but it sounds like there's like bedlam outside. So thank you, everyone.
Great, thank you.
I appreciate everyone's there's
So
my,
much.
another one, my 7th grader. Thanks everyone for everything you're doing for the schools, and let me know if I can help in any other way. And I'm happy to send the slides with the references if that's helpful.
that'd be excellent. Thank you so much for your time.
All right, take care, everyone. Thanks.
Thank you.
Thank you so much.
Okay, moving on. Next, we have our minutes from our meeting on October 21st, 2020. Are there any changes or corrections? I'm seeing none from the committee, so those can be marked as accepted as distributed. We do need to go into executive session this evening for the purpose of addressing Massachusetts General Law, Chapter 30A, Section 21A7, to comply with or act under the authority of any general or special law or federal grant in aid requirements. Purpose 7, open meeting law, Massachusetts General Law, Chapter 30A, Section 22FG, for the purpose of reviewing, approving, and or releasing executive session minutes. And B, for the purpose of addressing Massachusetts General Law, Chapter 30A, Section 21A3, to discuss strategy with respect to collective bargaining or litigation if an open meeting may have a detrimental effect of the bargaining or litigating position of the public body. And the chair so declares. Purpose 3, the Shrewsbury Education Association Unit A, Shrewsbury Education Association Unit B, the Shrewsbury Paraprofessional Association, and or the Shrewsbury Cafeteria Workers. May I have a motion that we adjourn to executive session?
So moved.
Second.
Roll call vote is required. Dr. McGee,
Aye.
Mr. Palich,
Aye.
Mr. Wensky,
Aye.
Ms. Heffernan,
Aye.
myself, aye. Thank you and good night.